The ThromboLink study is a prospective study that will look to implement a decision-supporting documentation tool for peri-procedural and peri-surgical management of antithrombotic medications using a virtual web-based format. The tool was designed at McMaster University, and the Niagara Health Thrombosis Clinic will be one of the main testing sites for the implementation phase of this tool. This particular research study fits well with the Niagara Health 10-year strategic plan goals, which aim to utilize regional integrated care to streamline ambulatory patient care and reduce the potential for human error in managed care. Each year, 200,000 people in Canada are assessed to manage their anticoagulants in the peri-procedural or peri-surgical setting. This assessment is required to reduce the risk for both thrombotic and hemorrhagic complications in the surgical setting, and there are clinical practice guidelines that give instruction on how best to do this. What is not known is if a virtual computer-based decision-supporting documentation tool might reduce the risk for complications, streamline this procedure with less utilization of resources overall. There are several well-designed studies and current guidelines that drive current practice for anticoagulant management. However, there is variability in the practitioner implementation of these practices, and a systematic approach should create an opportunity to reproduce positive outcomes and reduce variability and error. A progressive web application accessed through the internet offers an opportunity to provide more regimented application of the data and guidelines to this particular procedure. This application will be implemented at the Hamilton General Hospital initially, and after iterative reassessment, it will be implemented at other sites in the stage 2 of the phase, including St. Catherine's site of the Niagara Health Thrombosis Service. The outcomes measured for this particular study will include the fidelity of the recommendations using the web-based application tool when compared to the gold standard of blinded expert adjudication. There will also be measures of efficiency, looking at time studies for the use of the app. The acceptability outcome will be measured with both questionnaire and interviews with staff and patients, and some of this data will be used in iterative fashion between the first and second stage to refine the practical application. Finally, the fidelity, efficiency, and acceptability outcomes will be reported in a statistical analysis plan for quantification in the final analysis. The aim of this study is to validate the posit that peri-procedural and coagulation management can be done safely in a virtual fashion with a standardized computer-integrated framework. If proven effective, the data will be used to develop a definitive randomized control trial to help establish whether a new benchmark care delivery model could be widely adopted both nationally and internationally. We are currently in the initial preparatory phase of this study, with hopes to implement the second stage of the trial in the Niagara Thrombosis Service sometime in 2022.
Hello, everyone. I'm going to be presenting this presentation today on behalf of the team consisting of Leon Lee, as well as Dr. Andrew Zhao, Dr. Hannah Snyder, and Dr. Faraz Masood. We are presenting on the topic of ischemic stroke following discontinuation of oral antithrombotic agents in a regional hospital in Niagara. So we have no disclosures we have no conflicts of interest to disclose today. We just want to look at the association here between perioperative interruption of antithrombotics and the incidence of ischemic stroke at the Greater Niagara General Hospital. And we also had a secondary learning objective of kind of comparing the perioperative antithrombotic current practices against the current clinical practice guidelines, mainly taken from Thrombosis Canada. And so we know that antithrombotics are very important for primary and secondary prevention of stroke, and there have been studies conducted before on this very topic with a very similar research design, and we've cited those in our references at the very end. And mainly we've taken the guidelines from Thrombosis Canada. And there are guidelines present for proper interruption of anticoagulants like DOACs and NOACs, as well as vitamin K antagonists and antiplatelets. We won't go into the details of them, but they're all available. So our primary purpose was to examine the incidence of cerebrovascular accidents, so confirmed stroke via imaging, associated with perioperative discontinuation of antithrombotic medications. And we also wanted to assess the severity of the stroke. So we did determine the NIH-SS score for each person presenting with stroke and the Rankin scores, and to look at, again, the adherence of the guidelines in current clinical practice. And so we essentially looked at, in adult patients diagnosed with ischemic stroke, is there an association between cessation and ischemic stroke occurrence? So this was a single center retrospective cohort study. And we looked at as well comorbidities like dyslipidemia, hypertension, smoking, etc. So the inclusion criteria included any patient presenting to the Greater Niagara General with confirmed acute ischemic stroke. And we then analyzed these people for planned discontinuation of oral antithrombotic in the setting of planned procedure. We did not look at hemorrhagic stroke, we did not look at TIA, and if there was discrepancy around the timeline or if it was unclear when or which agents they were on, we also excluded those patients. In total, we looked at a sample of 517 patients, so a bit on the smaller side, but we were limited by resources and the small research team. And these are just some statistics there. We found 42% of patients were on antithrombotic therapy prior to the stroke. So that's 218 patients, and 26% on antiplatelets and 16% on anticoagulants. We actually found that there were a number of reasons for antithrombotic therapy interruption. Perioperative periprocedural was only the third most common, so 6 people or 1.2%. The most common reason was adverse bleeding event, and then there was non-adherence and contraindication. And we've gone into the 6 people with periprocedural discontinuation, what exactly procedure they had, and what antithrombotic they were on. And so this is just reiterating that. 7% of patients had their antithrombotic therapy interrupted, and of these, only 1.2% were perioperative / periprocedural plan interruption. And so this is just a further breakdown of the same data. So these are the people that were discontinued following adverse bleeding event. So you can see some of them were major, some of them were minor, and non-adherence was noted with apixaban, clopidogrel or Plavix, aspirin, and dabigatran. Again, going into some of the surgeries that required discontinuation, and then some of the contraindications. This is just breaking down into a timeline. So we actually found all patients had presented within 30 days. And you can see based on the timeline which agents they were on and what the reason was for discontinuation. And that is about it. So overall, what we got from this project was that periprocedural discontinuation is only one of the reasons that antithrombotics are discontinued, and we need to look into the other reasons more in depth. Thank you.
Implementing an automated electronic VTE assessment tool for ambulatory oncology patients, a Canadian Community Cancer Centre experience. Authors Lisa Rotz, nurse practitioner, and Dr. Blair Leonard, Niagara Health Thrombosis Service, St. Catharines, Ontario, Canada. Cancer patients receiving outpatient chemotherapy are at an increased risk of developing venous thromboembolism events. This is a preventable complication that can result in increased morbidity, mortality, treatment delay, as well as emotional and physical stress for patients. VTE risk assessment tools have been validated for ambulatory cancer patients, and the Karana score is the most well-known. Our aim was to evaluate the effectiveness of implementing an automated VTE assessment tool into the electronic medical record in a community cancer center and to gather data on rates of practitioner VTE assessment compliance, pharmacological thromboprophylaxis, and VTE events. We conducted a data analysis assessing the effect on clinical practice of implementing an automated VTE assessment tool into the EMR at the Walker Family Cancer Center, which is a community cancer center in St. Catharines, Ontario, Canada. This tool prompted a consideration for thromboprophylaxis in all patients identified with a Karana score of 3 or greater. A total of 4,354 ambulatory oncology patients at the Walker Family Cancer Center had the VTE risk assessment tool completed prior to initiating chemotherapy from June 2015 through August 2019. The practitioner compliance rate for completing the VTE risk assessment tool within 7 days of initiating chemotherapy was 98.3%. 8.7% of these patients had a high-risk score of 3 or greater. 93.6% of these high-score patients had a prompt sent to the physician for consideration of thromboprophylaxis. Total patients with a Karana score of 3 or higher were started on pharmacological prophylaxis was 2%. There was a non-significant decreased trend in thromboprophylaxis with time. We concluded that an automated VTE assessment tool resulted in higher rates of compliance for VTE risk assessment in ambulatory cancer patients in a community cancer setting, prompting for consideration of VTE thromboprophylaxis in highest risk patients did not appear to significantly alter clinical practice. Future directions: we have created a survey to identify potential barriers for thromboprophylaxis in oncology patients. We are creating pathways for patients with high-risk VTE scores, for example, a direct thrombosis service referral, dedicated oncology thromboprophylaxis clinic, as well as increasing patient education to encourage shared decision-making in thromboprophylaxis in cancer patients.
Systematic reviews are an extremely important part of the evidence-based hierarchy that we currently use. They serve to synthesize results from primary articles such as randomized control trials and observational studies to assist everyday clinical decision-making, as well as the development of beneficial health policies on a larger scale. As it is a type of publication that is at the top of the evidence hierarchy, it must have extremely rigid methodologies to ensure that the best quality research is available. As such, our team decided to conduct a systematic review that determines the reporting quality of the recent systematic reviews and meta-analyses in the vascular surgery field. This will be used to determine their adherence to the PRISMA statement, which is the preferred reporting items for systematic reviews and meta-analyses statement. Our systematic review was conducted on the Embase and Medline databases, and it reviewed every single SRMA from January 2010 to May 2020. Our inclusion criteria consisted of any systematic review or meta-analysis in the field of vascular surgery. The search was developed alongside a medical librarian that works at a health sciences library at McMaster University. Screening was done in duplicate with title, abstracts, and full text phases by 2 independent reviewers. We ensured to follow the PRISMA statement while conducting the systematic review. We also used the Cochrane risk of bias tool to assess risk of bias for every single included study. We used extremely broad keywords such as systematic review, meta-analysis, and vascular surgery to ensure that we cast the widest net possible. We looked for specific journals such as vascular surgery-related journals. And out of approximately 700 articles, 237 papers were included in systematic review. The median PRISMA score for these papers was 21 out of 27 items, which means that the majority of papers reported approximately 21 items correctly. However, a somewhat alarming finding is that no articles adequately reported the abstract according to the PRISMA guidelines. Additionally, many articles also failed to report the search strategy, as well as the presentation of data on risk of bias for both individual and pooled categories. The graph below shows a secondary analysis of the abstract of the systematic reviews, as no abstract met the required guidelines. The subgroup analysis of the abstracts revealed a median abstract score of 7 out of the 11 items that are written in the PRISMA statement. As abstracts are often the first and sometimes only section that researchers tend to read, this is an important finding. Also, well-designed search strategies are very important to capture all the relevant data. Ultimately, our findings suggest that improvements are definitely necessary for certain items of the PRISMA guidelines in vascular surgery systematic reviews and meta-analyses. Current surgical practice heavily relies on evidence-based medicine. Well-designed randomized control trials represent the gold standard when assessing the efficacy of different treatments. As such, the reporting quality of these RCTs is crucial to prevent biases when evaluating different surgical interventions. Consistently low reporting quality limits both the validity and generalizability of RCTs, ultimately impeding their inclusion in systematic reviews and meta-analyses. In an effort to standardize this process, the Consolidated Standards of Reporting Trials, the CONSORT statement, was developed as a guideline that demonstrates the ideal reporting of RCTs through 25 items, or 37 subtotal items. However, when it comes to surgical interventions, some common challenges include the complexity of procedures, patient recruitment, and blinding. The purpose of this study was to evaluate the reporting quality of RCTs in the field of vascular surgery. We conducted a systematic review and developed a search strategy for the Medline and Embase databases, and ran a search from January 1st, 2010 to July 30th, 2020. We used keywords such as randomized control trials and vascular surgery. These were extremely broad key terms because we wanted to make sure that we cast it as wide a net as possible. We also used the last decade as a period of inclusion, as the CONSORT statement was initially released in 2010, making that an optimal initial start date. 2 authors independently assessed the titles, abstracts, and full texts of every study that was included. A study was included if it was a randomized control trial that was in the field of vascular surgery. We did not exclude studies that solely focused on pharmaceutical interventions as long as they were still in the field of vascular surgery. The main outcome of this study, however, was the CONSORT score, or the sum of the total points that the study received out of 37. There were no half marks that were awarded to these points. Out of a total of 567 studies that were identified, 154 studies were included in this systematic review. We found that the median CONSORT score was 20 out of 31 items. We modified the CONSORT checklist such that it applied more to surgical interventions, hence the 31 items. However, the abstract was the least adequately reported item, with 0 studies out of the 154 meeting the CONSORT criteria. This sparked a secondary analysis that showed that the median CONSORT for abstract score was 9 out of 16 items, which means that the majority of studies only reported 9 out of the 16 necessary items that were prescribed by the CONSORT criteria. Other poor scoring items included methods for additional analyses, as well as the protocol. We also noticed that there was only 33% of RCTs that adequately reported implementation. This reporting could reflect a lack of transparency, as well as low methodological rigor in vascular surgery randomized control trials. However, as we mentioned previously, it has been exceedingly difficult to meet these criteria for surgical interventions when compared to pharmaceutical ones. One of the core limitations of assessing methodological quality using a CONSORT score is that it may not necessarily reflect the trial's design, as reporting quality may just be independent. For example, authors could have failed to report items that were properly conducted during the trial. However, ultimately, these findings still necessitate improvements in the reporting quality of vascular trials. We believe that this can be bolstered by enforcing the consort statement at the peer review stage of journal submissions, and even as a part of the requirements for submissions. However, there was a noted increase in percent compliance to consort over the last decade, and this may be due to the researchers gaining a better understanding of the consort statement over time. Randomized control trials are imperative for evidence-based medicine, as the results often inform clinical decision-making and practice. They should be methodologically rigorous and suitably powered to properly evaluate the effects of interventions. But sometimes, trials with a small number of outcome events may potentially produce inflated treatment effects, as a reversal of just a few outcome events could significantly impact a trial's conclusion. This is where we talk about the fragility index. The fragility index is a statistical metric that is used to evaluate the robustness of a study's conclusions. It uses the Fisher's exact test and iteratively reverses the outcome of one patient at a time in one treatment arm while keeping the outcomes of the other treatment arm constant. This process is continued until the trial's results lose statistical significance. For example, a fragility index of 2 would mean that the study would have 2 outcomes reverse the statistical significance of that study. Having established that the fragility index is the maximum number of patients in one arm of an RCT that would have to have a different outcome to change the results of the RCT from statistically significant to non-significant, we wanted to conduct a systematic review to analyze the fragility of randomized controlled trials in vascular surgery. We used a systematic search on the Embase and Medline databases and used a broad search strategy that involved the words randomized controlled trial and vascular surgery. Any randomized controlled trial that was in the field of vascular surgery was included, and they had to have a statistically significant dichotomous outcome. The studies also needed to be parallel arm studies, as studies with more than 2 treatment groups could not be included. Additionally, any studies with continuous outcomes were also excluded. Screening was done in duplicates for the title, abstract, and full text by 2 independent reviewers. Data extraction was also done in duplicates by 2 independent reviewers. We conducted a risk of bias assessment using the Cochrane risk of bias tool for randomized controlled trials for every included study. This review was performed according to the PRISMA guidelines. Our search strategy yielded 63 randomized controlled trials that were included for this review. The median fragility index of all of those trials were 0, and the range was 0 to 23, meaning that the majority of the vascular surgery trials did not have robust findings. To further elaborate, the low fragility indices that are calculated for the vascular surgery RCTs indicate that the study's results are extremely susceptible to be easily influenced by study withdrawals as well as loss to follow-up. A potential explanation for these low fragility scores could be a lack of power calculation and sample size calculation when deciding and designing these RCTs. However, when we did a secondary analysis to check if there was any correlation between the total sample size and the fragility index of a specific paper, there was no correlation that could be found. Ultimately, this method has a lot of limitations. Studies without a parallel one-to-one arm design had to be excluded, and other significant continuous outcomes also had to be excluded, as they could not undergo a fragility index calculation. This obviously limits the amount of studies that we could have included and leads to a loss of generalizability for the field of vascular surgery. There is also subjectivity involved when deciding concretely whether a study is fragile or robust due to the lack of any specific cutoffs provided in the literature. The majority of the included studies had a fragility index of 0, however. Although this is indicative of fragility, it provides limited information on specific improvements that we could provide. Ultimately, our future recommendations are that the fragility index calculations should be included in the consort statement, as well as the peer review stage of the journal submission process. The evidence suggests that vascular surgery RCTs with statistically significant dichotomous outcomes are frequently fragile. This means that healthcare providers should be cautious when altering their clinical practice according to RCTs with low fragility values, as they may potentially produce spurious inferences of benefit or risk.
Hello, my name is Sunil Upati. I'm an associate professor in emergency medicine at McMaster University and also appointed in health research method evidence and impact. And I'll be talking today about a new tool that we've created to evaluate conflict of interest in clinical practice guideline panels. By way of my own conflicts of interest disclosed and any other potential barriers, I have none. I have to acknowledge my collaborators from various parts of the United States and Canada, including Dr. Stevenson Strobel and our research assistant, Corinne Davy-Schinkel here at Niagara Health. So by way of introduction, clinical practice guidelines, as we've covered in another project being presented today, should be done in an open and transparent process to enhance the trustworthiness for their use in subsequent clinical practice. And conflict of interest amongst the guideline panelists can be a serious threat to validity and trustworthiness of the guideline recommendations that eventually we'll use in public health care. International organizations that create such guidelines have different mechanisms to evaluate conflicts of interest during the different phases of guideline development, and the transparency of the reporting of this can be suspect and or uneven. So the goal of this project was to make a simple to use evidence-informed conflict evaluation tool for a guideline panel chairs to use to evaluate the individual panelists' conflicts and magnitude of risk of bias, and then make decisions about whether conflicted panelists should be allowed to participate in discussing and then voting on clinical practice guideline recommendations. So our methodology was to start with a literature search across a comprehensive number of organizations, Guidelines International Network, national agencies, specialty organizations on the management of conflict of interest, and collapse them into some common assessment themes that ultimately resulted in 3 broad categories. There were financial conflicts, of which there were 14 specific domains outlining those, 5 academic, and personal conflicts, of which there were 4 different domains of such. So then we created a comprehensive panelist reporting form for the panelists to list all of these potential conflicts in the panels I participate in. Myself and another author, we created a hypothetical panel of 13 such panelists, and we outlined a variety of different conflicts across all these domains and what have you, and populated the reporting forms accordingly. The tool was then created to risk stratify overall risk of bias for each panelist using a Likert 1 to 5 scale. And then we had the raters ask questions about whether panelists should be allowed to participate in discussions. And finally, vote on recommendations using a yes, no, or need more information trichotomy of decision-making. We had 7 evidence-based emergency medicine and clinical practice guideline experts that were trained in the use of the tool. Then they applied this tool to the rating of each of the 13 hypothetical panelists. And finally, the results were pooled and categorized with consensus ratings and decisions, and we calculated integrated reliability for the tool using generalizability theory. So this is a sample of the conflict of interest panelist reporting form. There's some definitions of financial conflicts of interest here, and then the 14 categories are listed here, and the panelists would require to be answered yes or no, and describe yes for any disclosed conflicts, including how much cash they've been paid in these various conflicts over the last 12 months and the next 12 months to come in cutoffs of $5,000 to $10,000. Then there were the 5 academic conflicts of interest listed here with the definitions as well, but that they have to answer no or yes. And if yes, they have to describe their conflicts. And then finally, personal conflicts, 4 categories, no, yes, with descriptors thereof, and some references from where this information all came. Then the evaluator had to fill out this grid and say, okay, I've reviewed each one and to come up with a global risk of bias assessment, which could be then done on page 2 here, rated on a 5-point scale, either non-applicable, low, moderate, high, or very high, or need more information. And then finally, does the conflict merit exclusion of this panelist from discussing recommendations? No, yes, need more information. And finally, does the conflict form for that panelist merit exclusion from voting on recommendations? Again, no, yes, and need more information. So our results were, we had integrated reliability of 0.56, which is not fantastic, but the scales are relatively short, so it's not surprising. And a D study did show that the optimal number of raters for each panelist would be 5. The global risk of bias for the different panelists actually did show very high agreement, so we were satisfied with that, with the panelists we created. Raters were generally more permissive to allow conflicted panelists to discuss recommendations at a rate of about 80%, but they were far more restrictive and were at 54% in allowing the same conflicted panelists to participate in voting on recommendations. So there was a higher exclusion rate in this particular category. So overall, this is a pragmatic new tool that could be used by guideline panel chairs or other evaluators of the panelists to evaluate individual conflict of interest and then make reliable decisions on discussions and voting on recommendations with high reliability. So our future steps, the limitations of the study is these are ratings that have been done by EBM and guideline experts, some of which who have actually acted as chairs. So it'd be interesting to see if we could reproduce these results with non-experts, as it were. The ratings are, this is a deliberately hypothetical conflicted panel, which is, fictional, of course. So we could certainly apply this in the real world to see if it would perform the same if we were having the same tools for reporting, analyze, and come up with the same numbers. The opportunity here is, again, to use a real world application of this new tool in emergency medicine or other guideline development projects. We could repeat this exercise with civilian guideline oversight raters. Some organizations like the AHRQ in the United States is looking at having civilian oversight for guidelines and just removing medical people from the chair's position and anybody else who may have conflicts at that level, and just have a completely separate group that's non-conflicted to overview all of these guideline panels. So that's an interesting opportunity. And finally, the ratings here are not actually specific for guideline methodology specifically. These conflicts can apply across any research design. So if you have researchers who are doing randomized trials, systematic reviews, or any other types of research activities, you could use this tool to evaluate the conflicts of interest in those activities as well. So at this point, we'll take any questions that is appropriate, and hopefully have some idea about how to recognize conflicts of interest to them, and if not avoid them, at least manage them in an open and trustworthy fashion. Thank you very much. Hello, my name is Sunil Upati, and I'm an associate professor in emergency medicine and health research methods, evidence and impact at McMaster University. And I'll be presenting our project on rating the trustworthiness of emergency medicine guidelines using the NEATS instrument that was conducted last year. By way of relationships or any other conflicts, I have none with regards to this project. And I have to thank my collaborators, many of whom are community emergency physicians, those in blue coming from Niagara here, from our community sites within Niagara region, and some of my academic partners who also collaborated on this part, including Dr. Villani, who's also a Niagara emergency physician. So guidelines trustworthiness, why is this important? So the Institute of Medicine created their guideline trustworthiness standards articulated in 2011 in a document called Clinical Practice Guidelines We Can Trust. And these were codified into a trustworthiness assessment tool called the NEATS tool, National Guideline Clearinghouse Extent of Adherence to Trustworthy Standards, that was published 2 years ago by Ju and al. In Annals of Internal Medicine. And this tool is meant to measure the adherence of the various standards in various clinical practice guidelines that are published in the medical literature. So the goal of our project was to use this tool to look at trustworthiness of guidelines that are produced by the American College of Emergency Physicians, which is the biggest producer of clinical practice guidelines in emergency medicine worldwide. So our methods are, we started with the group of physician collaborators who were raters that were trained and in the use of the NEATS instrument using a training video that I prepared for the group. And we took current ACEP clinical practice guidelines going back to 2007, split them into 2 equal groups, so about 13 in each group from a total end of 20. And there were 3 guidelines that were overlapping, so we could do comparisons in agreement after everybody did their ratings. Raters also evaluated the overall guideline trustworthiness and implementability, which are the last 2 questions of the agreed to instrument, which is a different validation assessment tool for clinical practice guidelines methodological quality. So the rating scores were pooled and analyzed using descriptive statistics. We had cutoffs for different terciles of strong scores, moderate and low percentage scores based on percentage max domain score for all the different standards that are in the tool. And finally, we calculated interrater reliability using generalizability theory. So the NEATS tool itself, as you see here on the left, these are the different domains that are covered. So funding, disclosure, conflict of interest, membership of the guideline groups with regards to multidisciplinary groups, methodologists, patient public involvement, and then evidence processing with searches, selection, synthesis, and transformation into recommendations. And then finally, external review and updating. And these are the final 2 agree overall trustworthiness and implementation questions on 7-point Likert scales that are from that tool. And most of these over here are on 5-point Likert scales, or they're yes/no questions. So our results were that ACEP clinical policies in the groups that we analyzed were very strong with regards to guideline membership and methods, including evidence reviews, creating recommendations, updating plans. They were moderately strong in terms of conflict of interest reporting and external review, and they were low scoring with regards to patient public involvement. The NEAT scores did improve over time. Overall, the trustworthiness was very high across all of the guidelines that ACEP has produced. And implementability also improved over time. Finally, inter-rater reliability was quite satisfactorily high at 0.72, 8.2, and a D study showed that the optimal number of raters to look at any one guideline using this tool was 5 independent raters. So here's kind of a heat map of all of the guidelines we reviewed. The guideline assessment domains for NEATS is here on the left-hand side, including the bottom 2 ACEP policies. And from 2007 through 2019, which was our sampling frame, you can see that there's a lot of green scores that scored well, a lot of yellow scores that scored moderately, and this glaring line here over time, which was patient public involvement, which was uniformly poor over about 15, 16 years, and then eventually started to slowly improve in the last few years. So our takeaway from this is ACEP policies are generally strong in various NEATS domains and less so in others, and particularly weak in patient and public stakeholder engagement. The NEATS instrument did have high inter-rater reliability when used by emergency physicians in rating emergency medicine guidelines in this particular application of the tool. And overall, ACEP clinical policies are trustworthy and they're increasingly implementable into clinical quality improvement and patient safety activities. So they're ready to use in actual transformation into patient care improvement. So by way of discussion, the strengths of the study is that we had structured training of the various raters using the NEATS instrument. We had a mix of community and academic emergency medicine raters who were looking at both sets of guidelines in the 2 pools. We had them equally distributed. The ability to evaluate trustworthiness and implementability using the agreed-to final question domains. Limitations include, we only looked at the ACEP clinical policies. We didn't include any other emergency medicine guidelines that are written in a different style and written fashion. So we don't have information on those types of publications. Future directions, certainly we would want to apply the NEATS tool to non-ACEP emergency medicine clinical practice guidelines and see how they score compared to how the ACEP policy score. There was some item redundancy we noticed, especially on the evidence processing side. So factor analysis might be helpful to eliminate redundant questions and still maintain the reliability of the tool overall and make it easier to use. Finally, for guidelines author groups, you can use this as an end of project trustworthiness check prior to draft dissemination and final publication. That's something we did working with the Society of Academic Emergency Medicine's GRACE 1 guidelines that were published last summer. So at this point, I'll take questions and hopefully improve trust in clinical practice guidelines. Thank you very much.